We have Beth Attig. So Beth is a nurse practitioner with Penn Sleep Medicine. She is the lead clinical nurse practitioner and the clinical coordinator of sleep medicine for almost 4 years for Penn Medicine. She has a background in internal medicine prior to coming over to sleep. So we're excited to have her bring that wealth of knowledge over to us. She leads a team of 7 nurse practitioners with another to join them soon. And she's very supportive and knowledgeable about bariatric surgery. We're excited to have her with us. Now we also have with us Sam Simonson. So Sam, I'm going to ask her to introduce herself as well. We're excited to have her on as a guest as well to join Beth. She is, I believe, the program director for sleep medicine, and she is here to answer any of your scheduling questions, any of your other big programmatic questions that Beth may not be able to speak to. So at this point, I'm going to hand things over to Beth if she wants to say hi to the group and any words she'd like to share.
Yeah, welcome everybody. Thank you for coming. There's nothing better than telemed during a snowstorm, I guess. So certainly appreciate your ability to be here today. I really want to open this up. I don't know at what stage any of you are in the process of evaluation for bariatric surgery. We see patients from the very beginning to evaluate you for the need for a sleep study right through till you're ready to go to sleep and to surgery, as well as afterwards. We support you after you've been diagnosed with sleep apnea and might need treatment. So I want to open it up. I am a big cheerleader for sleep medicine in general. And so what you'll find is from most of the nurse practitioners and myself is that we are wanting you to love your CPAP, even and beyond getting through the surgical process. So we are very committed not only to getting you to surgery with compliance if needed, but also your continuance of therapy until you're at your goal weight. With that, I'll let Colleen let us know about questions. Or Sam, did you want to introduce yourself at all?
Sure, yeah, we would have Sam introduce herself. That'd be lovely.
Sure. Hello, everyone. So my name is Samantha Simonson, and I've been with sleep medicine. My whole career at Penn has been with sleep medicine. So it's going on almost 26 years. And maybe this will be helpful, but I did overnight sleep studies for at least 10 of those years. So hopefully if you are in the early stages and haven't had your sleep study yet, I can certainly answer those questions for you. But I welcome you all. I thank you for joining.
All right, excellent. Thank you, Sam and Beth. Awesome. So please take a few minutes, put in any questions that you have for Sam or Beth into the chat. I will say, though, we have one comment here from Deborah. Glad to see you back here, Deborah, who had surgery with Dr. Williams on December 1st. Had her CPAP for 5 years and love it, in all caps. Wonderful to hear. We have Beth clapping off to the side here. Excellent. So with that, I actually have initially a question for Beth to get us rolling. So I've heard this term so many times, and I really still don't think I fully get it. And I'm hoping you can help me with this. I hear the term often from sleep professionals, sleep hygiene. Yeah. What does that mean? Help me out here.
So a great question, and true for everyone, whether or not you need a CPAP. Sleep hygiene are your choices around sleep scheduling and what you do in the bed and out of the bed. So what we are looking for in sleep hygiene is, do you have a regular bedtime? Do you have a regular wake up time? Does that regular wake up time and sleep time correspond to weekends and weekdays? What do you do in the bed besides sleep? We joke in sleep medicine that the bed is for sleep and sex, and that is it. But many of us will bring our phones into the bed. We have TVs in the bedroom. We check our clocks a lot. We eat in the bed. We do a lot of things that are non-sleep activity in the bed. And good sleep hygiene generally involves a pretty nice set schedule, if possible, with your work schedule, as well as keeping other activities out of the bed. And for the purposes of this conversation, the big one is the phone or the tablet. Blue screen usage, blue meaning LED light screen usage, from a phone or a tablet is profoundly disruptive to good sleep quality. And that is probably the largest challenge for sleep hygiene among most of our patients. And that's the overall parameters of sleep hygiene. If you have further questions or want to comment on whether you've struggled with that yourself, please let us know.
Yeah, so that's very helpful, Beth. So I think starting off in the beginning here may be helpful. Everyone that comes to Penn Medicine to seek bariatric surgery, we place an order for a sleep study if they've not had one previously. And this is by request of you and your colleagues, and then also primarily our anesthesia group. So can you walk us through what's the purpose of this? Is sleep apnea really that common and people presenting for bariatric surgery, and like why does it matter overall to the surgical process?
So the main issue is that when you're overweight, you are at high risk of sleep apnea because your tongue and your throat may accumulate fat tissue or adipose tissue along with the rest of you. And so when you sleep, you are at risk at a certain level of overweight to obstructions in your airway. So in other words, when you're laying on your back, especially, and sometimes on your side, the fat tissue that accumulates in your throat area and your tongue can obstruct air getting through. And the typical things that you'll see is your bed partner might notice that you stop breathing in sleep. Snoring can also be related. And the way that you might feel, not everyone notices, is it feel like you've slept your 8 hours, but you really don't feel good when you wake up. Now, in the surgical realm, we are concerned that when you are done with surgery, now remember, anesthesia will breathe for you during surgery. So they will make sure that your airway is working and that you are getting a full oxygen complement that you need during the surgery. However, when you are done with surgery, we are very concerned that you maintain your airway. And what that means is basically, can you still get air, and oxygen through to where you need it? With people with untreated sleep apnea, they are at very high risk of what's called a respiratory arrest after surgery. So what can happen is, because your brain is not 100% with all of that anesthesia and the medication that you need, you are unable necessarily to maintain your airway on your own. Now, when you are at home, let's talk about what happens during sleep apnea when you are home. If you are not treated for sleep apnea, your brain is on alert all night, trying to keep you awake and alive and to make sure that your airway is working, right? So that's where, your bed partner might notice you going, gasping for air. That is your brain being a good sentinel or sentry and making sure that you are actually breathing all night. However, in the surgical realm, any kind of surgery, not just bariatric, because we sedate your brain to do the surgery, you are less likely to protect your own airway after surgery. And so we are very concerned here at Penn Medicine and across the board in the bariatric surgery realm to make sure that you can protect your airway after surgery. Now, that means wearing a Cpap if you are deemed to have sleep apnea during the process of evaluation. And so you will be asked to be ready to use a Cpap in the post-operative period. Now, there are some studies, and they are preliminary, to suggest that your brain is a little sedated when you go home. And so it is best to be planning to use your Cpap very consistently when you go home until you are completely over the anesthesia that you were given and the sedating medication that you were given. So we in sleep medicine and in bariatric surgery consider this absolutely critical to your safety during the perioperative process. And I'll stop there and see if anyone has questions about what I said.
Sure, that's wonderful, Beth. That's so helpful. And honestly, I think it's something that catches many people by surprise when they come in for their initial consult with us as to how I don't want to say concerned, but this is an area of weight management and obesity treatment and surgical obesity treatment that we really need to be cognizant of, especially from a complication standpoint. So thank you. All right, so we have questions. There are a lot of people who have a sleep study prior to surgery and find out that they have sleep apnea, or they already knew they had sleep apnea. They're looking to have bariatric surgery because they are looking to go into remission for having sleep apnea, right, and come off that Cpap, or potentially even a BiPAP, who knows. So we do have a few questions around this, including from Deborah, who's coming out, who's a little bit more than 2 weeks out. She had said that her last sleep study was in 2014. Will you do a new sleep study sometime post-op? So what's typically the recommendation as people lose weight to actually follow back up with you and your group?
So my general rule of thumb, and I won't speak for all of the providers because we all work a little bit, we try to listen to where the patient is with their weight loss goals. So usually I, work with the patient to find out, what is your weight loss goal? How long do you think this might take you to get there? And so I usually recommend that I see them 6 to 8 months after surgery. And I ask that they commit to using the Cpap until that follow-up visit. Because everyone loses weight at different rates, first of all. Second of all, you might lose a lot of weight in your throat and tongue, but the next person might not, right? We gain and lose weight along a hereditary pattern. And so most patients will lose a good amount of weight in their throat area, but I don't know that for sure. So what I generally say is, let's get to your goal, or at least your plateau weight. Hopefully that'll be in 6 to 8 months. And I would love you to commit to using Cpap that whole time. Now, I caution everyone I speak to, and I think most of the NPs do that there are patients for whom weight was not their only risk factor for apnea. And so there are a subset of patients who, even when they lose all the weight, will have some apnea, if not significant apnea, because they inherited a narrow airway from their family members. So I never make big promises, that definitively 30 pounds will do it, 50 pounds will do it, 75 pounds will do it, because I don't know exactly what that rate will be for any given patient, nor do I know that you didn't bring a narrow airway to the world with you, or that your family gave you that narrow airway prior to your weight gain. So, but generally the rule of thumb is commit to Cpap for at least 6 months after surgery. And then what I also say is, hey, if you're finding it very difficult to use Cpap prior to that 6-month follow-up, please reach out to us immediately. We will evaluate you sooner. And at that point, during that follow-up visit, we decide whether it's time to repeat a sleep study.
Okay, excellent. And I think you may have answered Stephanie's question in that answer. So I just want to make sure, though, that we caught you, got the correct answer for her here. So how long after surgery do I need to continue the Cpap if I've mild to moderate sleep apnea? It sounds like it's very individualized, and that requires an individualized answer. Am I hearing you correctly on that?
That would be correct. In most cases, mild apnea will resolve relatively quickly, right? But as I said, if you can keep it in your head that a good 6-month commitment is a good idea, that's usually a way to kind of look at it. But I've certainly recently heard from people who call me at 3 months. Listen, I've lost 50 pounds already, and I only had 10 events per hour. Do you think a sleep study is, a good idea at this point? I do ask every patient that I see to close the loop. In other words, please contact us and let us know where you are with Cpap, and let us consider a repeat sleep study, because we'd like to make sure that that isn't a continued risk factor for your cardiovascular and your cognitive health going forward.
Okay, excellent. And we do have an anonymous question here, but frankly, just from working with you all day in and day out for talking about after surgery, you often tell me in your nutrition sessions, my sleep has completely been thrown off. So many of you may be resonating, this may resonate with. So we have a question from an anonymous attendee saying, the most strange thing of all is I have a lot of energy. I started doing different hobbies to keep myself occupied, but the energy lasts more than 6 hours, and my sleep patterns are completely thrown off. Is there any evidence base behind this? I hear this often, and I don't even know. What can we typically expect for energy levels and sleep patterns with weight loss?
That's a great question, and requires sort of an individual answer, but because I don't know that we have any wide-ranging research to suggest that we understand that those changes. Generally, your sleep hygiene should stay the same in theory, right? So that if you sleep from 11 to 7 with Cpap prior to the study, you should probably still be on that schedule. However, I hear very often that people feel like they need less sleep after surgery, that they are more likely to bounce out of bed in the morning. And I don't always know if that's because they've been wonderfully compliant with their Cpap usage or because they are breathing better at night. Let's not forget that when we lay down, the extra adipose and fat tissue that you have in your trunk, your abdominal cavity, is going away too. And prior might be actually compressing your lungs a little when you sleep. And so you are potentially getting more oxygen at the base of your lungs, not just through your throat because of your Cpap usage. So all is to say that I don't think there's any specific research to suggest that there are major changes in sleep. However, I do remind you that especially in the early postoperative period with bariatric surgery, you must get enough calories as you're recommended. You must get enough hydration, and you must keep a close eye on your vitamin status as per the bariatric surgery team. Hydration, calorie intake, as well as vitamin status can affect sleep quality and quantity. So, as you are adjusting to all of that with weight loss, please check in with your bariatric surgery team about that status, and then let us know if there seem to be some underlying issues with either insomnia or which we also have a program in insomnia, so don't ever forget us for that. We have that availability. Or if you're not able to get on track with your sleep hygiene, we are available not just for Cpap, but for those questions as well.
Excellent. Okay. And that is something for nutrition-wise, many of you will ask me immediately after surgery, I just feel beat. I'm so tired. I get exhausted easily. Like I feel better, but I'm really tired easily. And Beth, you hit a lot of really good points. We start talking about, are you hydrated? You're also losing weight quickly during this time. You're recovering from a major operation. There are a lot of different things going on. It's hard to pinpoint which one of them it may be, but it's a lot of investigating that.
Yes.
That's our step one with us. All right, excellent. So let's shift over to a little bit more long-term. So Greg is asking, it's been more than 2 years since surgery and his doctor has not yet suggested a repeat sleep study. When should I bring it up with him?
As soon as you'd like. I don't know Greg's specific history, obviously, but if you have gotten to plateau weight, it would be definitively recommended. It's interesting. I want to mention that I have a patient who lost 150 pounds, and he had been on Cpap for many, many, many years prior to considering bariatric surgery. And when we suggested that we repeat his sleep study, he said, oh no, I love this thing. You're not taking it away from me by telling me I don't have apnea. So there are people who certainly do not give up their CPAPs because they have learned that it does give them better sleep. However, at 2 years, depending on where you are with your weight loss, Greg, it would be very reasonable to consider. Now, if we're able to do a physical exam, right now we've done a lot of telemed visits, we can take a good look at your airway when you come in for a visit. And so we can take a look and see, what does your tongue look like at this point? Does it look like, you know, what's your neck circumference? You know, was it 19 and now it's 16? You know, those are risk factors that we look at for the sleep apnea, but as that resolves, is that something that suggests that you may no longer have apnea? Now, for those who are CPAP users, you may notice that you don't love the pressure that you're feeling once you start losing weight. So in other words, does it feel like too much pressure? And that's sometimes an indication that your apnea is improved, if not gone. And so I would discuss all of those issues with your provider, and we'd be happy to help you individually for that.
Excellent. All right. And let's shift over. Cheryl has a great question here, and always appreciative to switch over from talking about any CPAP machine usage and just general sleep hygiene. So if I can't fall asleep for an extended period, should I continue to rest in bed, or should I arise and work on a project until I become sleepy? This happens occasionally for a variety of reasons. What do you think, Beth?
What a fabulous question. Thank you. So what we teach in our cognitive behavioral insomnia program, which I will say has 40 plus years of research behind it, much of it done at Penn, what is suggested is that you get out of bed. So the longer that you struggle to sleep, the longer that your brain associates the bed setting with struggle. Remember, I said a little bit earlier, sleep hygiene should be the bedrock of sleep hygiene. Forgive the pun with the bed, is that the bed is only for sleep and sex. It is not for struggling. It is not for reading a book. It is not for counting sheep. The minute that you are willing to count sheep, or as I joke, invite the sheep into the bed with you, the more chance is that your brain is becoming confused about what to do there. So, bottom line, have a chair in your bedroom. Have a chair in another quiet room if you can. Get up to that chair and do something quiet. You can pick up a deck of cards and play solitaire. You can get a coloring book and color for a little while. You can use a low light and read a book or a magazine. You can do something for about 15 or 20 minutes, as long as it does not involve a phone, a tablet, or the TV. You, again, do not want to engage blue screens at that time of night. Get up to the chair, do something quiet, distracting for 20 minutes or so, and get back to bed. And then if that doesn't work, get back up again. What you are doing is you are reminding the brain that the activity, the rumination, the frustration, the insomnia belongs in the chair briefly. And then when you generate sleep again in the bed, your brain has associated the bed back with what it's supposed to be doing. Now, that may sound complicated because most of us lay there and try harder to sleep. I will tell you, you can try harder to exercise. You can try harder to watch how much ice cream you're eating. You can try harder to do a lot of things that are self-care and good for your health. You will never succeed trying harder to sleep. It is a process that is somewhat beyond your smart human brain to fix. So try that little trick. And if that does not work, please call us. We do have a wonderful set of sleep therapists, myself included, and a sleep psychologist who can help you in your individual case.
Excellent. All right. And we have a question from Donna here. We're going to shift back over to a CPAP question. So she's been told by 2 different providers, not at Penn, to put some context to it, that she has very mild sleep apnea now and doesn't need to use her CPAP. She says she's sleeping without it. Is it okay to use again sometimes?
It's safe. So yes, it would be fine to use it. One of the things that's interesting about sleep apnea, unlike other medication therapy, is that generally piping air into the back of your throat to open your airway, even if your apnea is mild, is not going to cause any complications. If it feels good to you and you feel like you sleep better, you are welcome to continue therapy. We are not, you are not obligated to in most cases, although I don't want to speak specifically to your case, but generally it is safe to continue. And I'll, harken back to that patient who lost 150 pounds. Chances are he did not have apnea anymore, but he was used to sleeping with it. And so we didn't argue about him continuing it. If you feel better, then chances are your apnea is affecting your day-to-day functioning, and it would be perfectly reasonable to continue usage.
All right, excellent. And so this is more of, this wasn't asked in the chat, but it has been in previous support groups. And frankly, it's a question that I'm getting often via my Penn Medicine from patients. We're hearing a lot about CPAPs and COVID, and a lot of concerns around in household transmission.
Yes.
Or bringing it into the hospital when they do come in to have surgery. What is the current state of where we're at with CPAPs and COVID? And what can you tell us about what we may be looking towards for those that are preparing for surgery and potentially needing a CPAP when they're in the hospital?
Okay, so the issues in the hospital are evolving, right? So I don't want to speak directly to that yet, but I will tell you what households, because that's really where more of my experience lies. Let me tell you a little bit about the American Academy of Sleep Medicine's recommendations, which came out, Sam, I don't know if you can correct me, I want to say April, May. It was not immediately when the pandemic started. April, right? Yep. The recommendation is that if you are confirmed COVID or have suspicion that you may be infected or have an even unknown exposure, which you think might be serious, you are to stop your CPAP usage and call your provider immediately. Now, obviously, there are asymptomatic spreads, so you may not be aware of these issues, but if you are under investigation or have symptoms that you are concerned about, and I can review those in a minute, you are to stop using your CPAP, because the act of using positive airway pressure may spread the germs to your bed partner or beyond. So if you are in a room with another person, or if other members of your household might be in and out of the room where you use the CPAP, there would be a high risk, or I shouldn't say that we know the exact risk, but there would be enough of a risk of transmission of the virus because the positive airway pressure has pushed the virus into the room. Now, in many cases where my patients have been COVID positive, we have been lucky. There have not been other members of the household who would have been exposed. And so in those cases, when they have contacted me, I have said, you may continue to use your CPAP because you are not exposing anyone else at this time. So the first rule of thumb is to contact your sleep provider. Let us know where you are in the process so that we can talk you through it. We would love you to be able to continue to use your CPAP, but the first rule of thumb is to practice that safely with help. Now, we were using CPAP and BiPAP again in the hospital prior to the latest surge. So I have to admit to some ignorance about what we are recommending from the bariatric surgery realm or for other surgery patients at this time. I don't know if you can comment further, Colleen or Sam.
Sure, Sam, I'll let you come up first.
Sure. As Beth said, it is evolving. I know that there will be new procedures and policies in place. I believe that if patients are able to be in negative pressure rooms and isolated, that they may need this therapy while they're inpatient. But there is this concern about the aerosol air. And I did want to add also that for patients coming in for testing with us, we do coordinate COVID tests prior to in-lab sleep studies. not the home studies, the ones that you take home with you, but the sleep studies where you're staying overnight in any one of our facilities, we do coordinate that with you. So we are doing CPAP and bi-level titrations in our lab environment, but it is very under very safe conditions. So we'll see what happens on the inpatient side. But right now, that's all I have.
Yeah, so I can somewhat add to that. So when you come in for your history and physical with your nurse practitioner prior to surgery, they will let you know what the latest recommendations are. And Beth is exactly right. There are two different things that really drive this. Is one, what's your severity of your sleep apnea? That's a big one, right? Do we really need to make sure that you're on a CPAP when you come in? And two, are we able to get you into a negative pressure room when you're here? It's typically only one overnight for most people, right? So we're only looking for a room for one overnight, but as many of you know, beds are at a premium at this point. So we would have to get one of those specialized rooms that's a negative pressure room. So the nurse practitioner would walk you through at the time of, we need to go through a process. If your sleep apnea is mild enough and it's not something that we would need to have you on for one overnight, then the nurse practitioner would walk you through the recommendations then, but it's very individualized. And the goal out of this is to keep everyone as safe as we can and minimize risk wherever we can. So that's very helpful to know though, Beth, for like bed partner COVID transmission risk mitigation with CPAPs. All right. So Deborah has an additional question here, and we'll make this our last one for today. We hear often, especially in bariatric surgery, all about devices. She's heard about this Inspire implant, and we've seen commercials on this. Do you mind just speaking to what are some of the devices that are coming out? What's the general recommendation at this point? Any thoughts that you might have on them?
Yeah, so the hypoglossal nerve stimulator, let's call Inspire is a brand name, so I want to make sure that we back off of that a little so that I can explain, what that is. That's the main device that we're seeing right now, so I'll just focus on that one so everyone knows what that is. A hypoglossal nerve stimulator is a device that is implanted in your chest wall, similar to a cardiac pacemaker, and what that does is it sends a impulse or a wire up to your hypoglossal nerve, which is your tongue nerve. And when it is turned on, and I'll explain that in a minute, it creates tone or extra strength in the back of your throat in your tongue. So what it does is it actually results in your tongue kind of pulling away from the back of your throat. And so what you do, and you may have seen the commercials for it, there's a young man who's shirtless who takes who probably doesn't have apnea because he's really buff, but it kind of cracks me up. He's a younger man, and he takes a magnet-ish type of device and turns on his device, which, as I said, is in his chest wall, and he turns it on when he goes to sleep, and then you turn it off when you get back up. And so now there are criteria for this. You cannot have a BMI over 35, if I'm not mistaken. So in other words, if you know your body mass index, many people need to lose weight to be considered for it. So this would probably be something for most bariatric surgery patients that would be for any leftover apnea once you've lost your weight. And you probably can't have anything more than moderate apnea. So moderate being 15 to 30 events per hour. And those of you who've been through the process know what that's about. We are very lucky to have a sleep, ear, nose, and throat doctor who is very well versed in evaluating patients for this. And so if at some point, probably after you've lost part of your weight and you've been retested, you would possibly be a candidate for Inspire. Now, prior to surgery, if you have been diagnosed with mild to moderate apnea, you would not be a candidate for the hypoglossal nerve stimulation because, first of all, insurance would require a trial of CPAP. Because it does not pay for the surgery unless you failed on CPAP. And more likely than not, you are going to resolve your apnea with weight loss. And so, you know, we need you to adapt to CPAP to get you through surgery, as we talked about, and then beyond surgery until you get to your plateau weight. At that point, any one of you who, you know, our patients would be eligible for the repeat sleep study and a discussion of the hypoglossal nerve stimulator or Inspire.
All right, excellent. And we did, while you were explaining that, Beth, we did get a response from Deborah, who said, "Ugh, completely gross. Sorry, I asked." When you had mentioned how it's placed, so I think that that's what we oftentimes hear about some devices once you actually get into the technicalities of how it works.
That's advertising for you.
Yes. All right. Awesome. Well, thank you, Beth, and thank you, Sam, for joining us today.